Hello, and welcome to LAIVF's podcast series, Understanding Your Fertility, a podcast series specially curated to answer all your questions about fertility with fertility specialist Dr. Aykut Bayrak. And I am your host, Ara Behagan. Today, we will be discussing what happens when fertility treatments fail. Now, in a previous episode with Dr. Bayrak called Failed IVF, we talked specifically about IVF treatments and when that fails. Since that was such a popular episode, we decided to do another one where we could cover many other types of common fertility treatments and when those fail. To help make this an easier podcast to understand, we ended up breaking down this topic into 3 categories. The first, what happens when surgical fertility treatments fail? Second, what happens when medical treatments fail? And thirdly, when using an egg donor or surrogate fails. And as Dr. Bayrak reminds us, there are many variables that we just can't possibly cover in one episode. So we encourage you to go and speak to your local fertility specialist who can diagnose your particular case. And as always, if you have any questions or comments that you would like us to address in future episodes, please email us at info@laivfclinic.com. And to help us find your email quickly, please add to the subject line the phrase, "My fertility questions." And thank you so much for listening. Thank you for joining us today. Our topic is when fertility treatments fail. There is a common misconception out there that fertility treatments are a gamble or a shot in the dark with a lot of money wasted. And what we really want to talk about today is the science behind what goes into fertility treatments and how and when they succeed and when they fail. The ultimate goal here, of course, is for all of you listening to go and speak with your local fertility specialist who can diagnose your particular case and your specific odds of getting pregnant. Now, in a previous episode called Failed IVF, we talked about the differences of when fertility treatments, when IVF specifically fails, and the solutions for that. In this episode, we are going to cover topics such as surgery for infertility, Clomid, IUI, and we will talk about IVF, but we will talk about it in regards to if you have a surrogate and if that IVF cycle fails, or if you're using donor eggs and if that IVF cycle fails, what's happening. So without further ado, I'd like to introduce Dr. Bayrak. Hello, Dr. Bayrak.
Hi, Araba.
Hi. So let's get started with the topic of the day, which is when fertility treatments fail. Can we begin with surgery for infertility and when that fails?
Yes. So I think that's a good place to start. So we can talk about surgical treatments of infertility and medical treatments of infertility and what to do when they fail. So surgical treatment of infertility is not as common as it used to be compared to 20, 30, 40 plus years ago. It was more surgical treatment back then. And now that we have IVF, which results in a much higher pregnancy rate than 20, 30 years ago, surgical treatment of infertility is probably less common these days, although it's still certainly an option for us. So typically, if it's surgical treatment, that means there is something that's identified already, such as ovarian cysts or fibroids, or somebody has endometriosis. and or at a very high risk for endometriosis, and they're having surgery for treatment of these issues. Once again, fibroids or polyps in the uterus, cysts in the ovaries, some kind of scar tissue maybe in the pelvic area, or endometriosis. And the patient is having surgery for these issues. For the purpose of the podcast, what do we do next? What kind of a conversation do we have when we do surgery? And then we let these patients go for a little while because they would have surgery, then you would treat the underlying cause, right? If they have fibroids, then you would remove the fibroids. If they have polyps in the uterus, you would remove the polyps. Or if they have a cyst in the ovary, then you would take that cyst out. If they have endometriosis, you would treat the endometriosis, remove the scar tissue perhaps, and then we would then have the patients heal for a month or so. And then we would say, well, everything's treated now, everything else looks good. So why don't you try for 6 months or 9 months or 3 months or a year, depending on their age, depending on other coexisting issues. And then if they get pregnant, that's great, obviously. If they don't, then they would come back.
So can I ask you a question here then, which is for ovarian cysts, fibroids, polyps, endometriosis, scar tissue, what is happening there? Is the ovarian, is the lining of the uterus being blocked, or is it that the egg can't attach?
Yeah, some of that. So if somebody has endometrial polyps, these are soft tissue growths in a way inside the endometrial cavity. So there are polyps in a lot of different places in our body, right? In the colon, there are colonic polyps. You can have polyps in the vocal cords, right? It's almost like a skin tag that's inside your uterus, which can create a hostile environment for the sperm, for the egg, for the embryo. So that can interfere with implantation. If you remove it and normalize that area, the anatomy, then you would restore a normal implantation process. So if you remove a fibroid, if you remove polyps, then you're restoring anatomy, and then the embryo then can implant. So that's how that would accomplish pregnancy. If it's endometriosis, I think we did maybe 1 or 2 episodes, maybe more than that, right? So we did talk about that quite a bit. So for interested listeners, please go into our podcast and search for endometriosis. There should be at least 1 or 2 episodes there that you can actually read about or listen to. And also on our website, you can actually read about it. So endometriosis can cause infertility due to a variety of different reasons. From a surgical perspective, it can cause scar tissue. It can cause distortion of the anatomy.
Oh, interesting. Distortion, meaning a different shaped uterus.
It can cause scar tissue where the uterus can kind of be pulled to one side. The fallopian tubes can be blocked or pulled up or down. They can be completely blocked. They can be partially blocked, affecting their function in a way. And also some women have advanced endometriosis where they have ovarian cysts called endometriomas. So the treatment of that from a surgical perspective would be, once again, to normalize the anatomy, restore the anatomy, open the tubes or free up the tubes, remove the cysts, and then allow these patients to try to conceive for a number of months. And that would kind of be the approach. And then the question is, what do we do if they don't get pregnant, right? So that's kind of where I think need to concentrate.
Right. So if it sounds like to me what you're saying is that there are multiple variables beyond just maybe the initial diagnosis of maybe ovarian cysts, et cetera, but we also have to consider different things like age, egg quality, et cetera. So there's a lot involved. If those treatments fail, there might be other things underlying.
Right, absolutely. So we typically would evaluate the patient and the partner before doing surgical treatment anyway. So we would know if there's a sperm problem. We would know if there's an ovulation problem. We would know if there is a low egg reserve. So we would know all of that in advance. But let's just assume that everything is fairly normal during that assessment, and then we do some type of surgery and it doesn't work. And then once again, depending on each individual case, and there's no set formula for this. If everything else is good on the surface and we treat the problem, the underlying cause during surgery, we'll give them somewhere between 3 to 12 months of trying. And if that doesn't work, when they come back, we would reset and reevaluate to just make sure that nothing else is happening with them. The few challenges after surgery can be recurrence of those issues. For example, if somebody had a polyp, they can come back. Sometimes smaller fibroids over time can grow back. So that you can have these recurring problems. Endometriosis can recur. And endometriosis is tricky because sometimes you remove the cyst or the lesions, but it's still deep in the tissue. It's almost like you have a tree with the roots and you cut off the tree, but the roots are still there and they still cause problems and trouble. So endometriosis sometimes is unfortunately a lifelong issue that women suffer from. And it can come back, it can recur. So the exact issue that you did surgery on may actually come back after a certain number of months or years, again causing problems, and the underlying cause can still be the same. In terms of ovarian cysts, especially if they're endometriosis cysts, the larger they are, the more complex they are, the greater likelihood that they're going to recur. And that happens over time. It doesn't happen a month or two after surgery, but it can certainly happen within the first year or two. So the longer we wait after surgery, the likelihood that the underlying cause, why we did the initial surgery to begin with, can actually come back. So that should not be overlooked. And then all the other coexisting problems can then cause infertility and result in that failed treatment, quote unquote, in a way. So, for example, if somebody had multiple fibroids and we do surgery, that type of surgery actually can cause scar tissue. That's one of the surgeries that certainly can cause scar tissue. If somebody had endometriosis, it can come back. If somebody had advanced endometriosis and when you remove cysts, inadvertently, you're going to be removing some healthy tissue. And there are a lot of studies that looked at this. So after surgery, you're doing a good job and cleaning up, but then you may have lowered the egg reserve at the same time. So now you're not only dealing with, potential issues down the line with endometriosis and recurrence and inflammation and its impact, but also now you're dealing with low egg reserve. So somebody has to kind of look at that and decide whether surgery is the best approach to start with or not. But if it was because the cyst looks suspicious or the patient has severe pain or the cyst was just so big, it was just imminent that there will be a complication like rupture of that cyst, right? So sometimes you just can't hold off on surgery. You have to go in. But there are consequences to that, especially with large endometriomas. And I think we talked about that maybe in the past. So you can actually lower the egg reserve after surgery, not intentionally. It's just the nature of that surgery. So when these surgical treatments fail, these may be some of the consequences that one has to look at and then move on to other treatment modalities.
Okay. I would like to talk as well about Clomid. Now, I know a lot of patients, especially if they start off with their OBGYN, they'll start off with a Clomid treatment. So can you talk about when that could fail and why that may or may not work?
That's a good idea. So we just talked about the surgical approach. Obviously, there's so many variables. There are different kind of surgeries that we are not covering during this podcast, which certainly that kind of discussion should take place between the physician and their reproductive endocrinologist and infertility specialist, because there are also uterine anomalies, like hysteroscopic removal of septum and scar tissue and all of that. And they can certainly come back, or there can be other issues related to that. So we're certainly touching base on some of these procedures, but there are many other procedures that we do and patients undergo that can certainly fail But we'll just leave it at that for discussion of the podcast for now, and then switch to medical treatments. And what do we do when certain types of medical treatments fail? And you brought up Clomid, which is a pill that is often used for fertility treatments. Clomid is probably the oldest fertility medication. It's a pill, and it allows the body to release more hormones from the brain, which then enhances ovulation. Sometimes it makes somebody release more than one egg. It also restores ovulation in women who do not ovulate. There's another drug called Femara. So that's also quite popular these days. And they kind of can be used interchangeably with Clomid. At some point, people thought Femara was better, but later studies actually do not show that it is actually better. So it appears that they each have their own kind of strengths in certain conditions, but certainly they can be used equally in making somebody ovulate. So they're typically used for somebody who doesn't ovulate, who gets their periods every 7, 8 weeks or 10 weeks, or doesn't even get their period at all. And then it makes that person ovulate. So it kind of restores ovulation. And then sometimes it's used for women who actually do ovulate. They have regular periods, but they take these medications to release more than one egg. That's called superovulation. So it kind of makes their ovulation stronger, and it also allows them to release 2 eggs as opposed to 1, which is almost like trying for 2 months, right? So those are some of the indications for Clomid and Femara, and that's typically one of the most commonly used approach for early infertility. So if somebody's not ovulating or they have early infertility and everything kind of looks okay on the surface, then people just start Clomid and Femara, and then they continue for anywhere between 2 to 4 months. And then the question is, what do we do when it fails?
Yeah, that's my question is if you're trying for a couple of months and look, if we're over 35, we really only have 12 times a year to try, right? So our time is limited, especially if we're over 35. So if it doesn't work, is it that there is low egg reserve and so there's nothing there? What's happening?
Yeah, it might be. So if it's an ovulation problem, the most common ovulation problem is PCOS, polycystic ovary syndrome. And that's one of the most common reasons why Clomid and Femara are used for. So the key there is to make sure that the patient is ovulating. So sometimes patients just take Clomid and they miss their period, which means they never respond. So then if that is the case, then the dose has to be adjusted. So you just can't take Clomid back to back without any response, without getting the period, and without any monitoring at all if you're not responding. If you're responding, meaning you take Clomid and then about a week or 10 days after you ovulate and then you get your period, obviously you responded, right? But if that hasn't happened, then you need that next level of treatment because you failed that kind of particular cycle or dose where you have to increase the dose to find that dose where you can actually ovulate. And once you find that dose, then you stay on that dose because that means you're responding, you're ovulating, and you can continue that for up to 6 months, even up to 7, 8 months, as long as you accomplish your goal, which is making that patient ovulate, right? But let's say you accomplished that already and the patient is ovulating and still not pregnant, right? So if that happens in somebody above the age of 35, that's probably related to egg reserve or egg quality, which is something that you just brought up a few minutes ago, especially after 38, when Clomid really doesn't work that well. That doesn't mean that it doesn't work at all. We're not saying that, but it seldomly works.
Okay.
So that doesn't mean that it cannot be tried, but it's just that we have to understand it's just not strong enough.
Okay.
And sometimes there's just more to than ovulation than, just taking some pills and trying to get pregnant that way. So there can be issues with tubes where maybe the tubes are not 100%, or maybe there are some sperm problems. Or everything is good. It's just the egg quality is now being affected because of reproductive age. And that's why the patient is ovulating, but the egg is unhealthy. So ovulation is one thing, obviously, but there are many more steps after that that have to take place to accomplish healthy pregnancy. And maybe those steps are just not working.
Right.
So that's kind of why somebody may fail Clomid or Femara. I didn't talk about Femara, but I would just say everything that I'm saying with Clomid kind of covers Femara as well. And if that happens, then they move on to the next level in their treatment.
So, okay, that's really helpful to hear about Clomid. What about IUI? And why wouldn't that work sometimes?
Yeah, so IUI is intrauterine insemination. That's what it stands for in medical terminology, or it's also called artificial insemination, right? So it refers to taking a sperm and injecting it through the cervix, where we do pap smears, right, all the way into the uterus. So that's why it's called intrauterine, where the sperm is injected all the way into the uterus, where we're bypassing the cervix, which acts as a filter, right? So after regular intercourse, sperm is deposited into a private vagina. And then from there, the strongest sperm can simply swim through this filter system called the cervix, and then make it all the way into the uterus. Then the sperm would swim into the fallopian tubes and find the egg and fertilize the egg. So from millions of sperm, sometimes there's just a few thousand that actually make it to the egg, where they have that option or opportunity to fertilize the egg. So if there are issues with the sperm, where the sperm motility, which is the swimming ability, is not that great, or if there's a problem with the count, the volume is a little low, the count is slightly low. So if there's mild male factor infertility, typically IUI does work because you're somewhat treating the cause in the sense that you're getting more sperm up where the egg is at.
Right.
So if that is the issue, then Clomid or Femara can be combined with an insemination, or it can be added on when Clomid or Femara actually fail. So that certainly can be done. And Clomid is fine, but sometimes there are timing issues. So after a month or two of possibly just using what we call time intercourse, just simply trying when the ovulation test is positive, it's not a bad idea to add on the insemination method, where the infertility specialist monitors the patient, determines when exactly ovulation is taking place. If there's no ovulation, then ovulation can be forced. It can be induced by an injection. That injection is called HCG. We call it the trigger shot because it triggers ovulation. And then the insemination can be then timed. So if there's a timing issue, male factor infertility, early infertility, and or when Clomid alone fails, IUI then becomes a good, helpful tool and pretty much next step.
Okay, fantastic. That really helps to clarify a lot of that. And just one more quick question with IUI. So when you do an IUI and you take the gentleman's sperm, it's different from ICSI, where you just take one sperm and inject into the egg. You're actually taking a bundle, basically, and inserting into the vagina, right? Correct? Or into the uterus.
Exactly. So the insemination is after collection of the sperm, you process the sperm and get some of the debris, the white cells, some of the dead sperm, any kind of additional antibodies that may be present. So you, through the processing of sperm, you get rid of all of that sperm, and you get kind of the better part of the sperm isolated and separated. And then you go through the cervix and inject it into the uterus. And then from there on, everything still has to happen naturally. Sperm, they have to swim into the tubes and fertilize the eggs, and then the embryo has to form. It has to then travel back into the uterus and attach. So once you inject the sperm, you're not done. So you just accomplish one part of the whole process, where there has to be a lot of other processes that still have to happen, right? With the ICSI, as you brought up, which stands for intracytoplasmic sperm injection in medical terminology, or microinjection of the sperm, or putting one sperm into an egg under the microscope. That's what it means. That typically refers to IVF, in vitro fertilization.
Good. Let's talk about IVF as well. Talk about ICSI, and then also talk about when we're using a donor or surrogate.
Yeah, so basically, if the IUI fails, Clomid fails, and or surgery fails, kind of the last resource become IVF, in vitro fertilization. And IVF basically involves taking hormone injections to develop multiple eggs, followed by retrieval of those eggs from the ovaries, fertilization in the laboratory by sperm, right, with husband partner sperm, and then creation of embryos, and then testing those embryos possibly with pre-implantation genetic testing or not, and then implanting an embryo into the uterus called embryo transfer. So that's IVF. And we did talk about failed IVF in our previous episode, so we probably should not repeat that for the purpose of this session, but for our interested listeners, I would want to refer you to one of our previous podcasts called Failed IVF. And if IVF fails, what can be the reason? What are the causes? And what can be done next? I think today's podcast, I think we're going to talk about what some of the third party or advanced type of IVF treatments fail, and what do you do in the next few minutes, as opposed to just simply what happens when just IVF fails. So if IVF fails and somebody used, for example, donor eggs, and again they failed, right? So we created embryos using donor eggs because the egg quality was low, and we said, well, let's use donor eggs to bypass that because that would solve it. And then we create embryos and transfer them, and it still doesn't work. So what can be the cause of that? What to do? What would be the next option, right? So if that happens, it's always a good idea to reset and go back and look at every single variable. And I typically reevaluate the fallopian tubes, reevaluate the uterus when something like that happens. And then I also do advanced sperm testing. Look at the sperm DNA, look at habits, exposures, and try to find out whether there was something more than just simply using donor eggs and trying to solve the problem. Were there any other variables like endometriosis? Were there any anatomical problems with the uterus? And whether there was a genetic issue, despite the fact that we use donor eggs, which everybody assumes that the donor eggs are perfect, but they're not. And you can have really bad eggs coming in from an egg donor. The egg donor could have been exposed to something. Sometimes the egg donors may not be as compliant as we want them to be, right? So that's always a question mark, always a variable. And if something like that happens, we look at all those variables and identify. And if everything is still perfect, and if the couple has exhausted all of the created embryos already, then we typically recommend using a different donor. So we say select a different egg donor because clearly everything else is fine. We look at all the other parameters again, and again, they're fine. And the sperm is perfect and everything else is good. Then it's gotta be the egg donor. Maybe she was exposed to something or something happened. So so the bottom line is, or the take home message is, do not assume that the donor eggs, frozen or fresh, collected, doesn't matter, are perfect, because they may actually be quite abnormal.
Thank you. That is super helpful to understand if somebody uses a donor egg and that fails. How about if somebody uses a donor sperm? And what happens when that fails?
Yeah, so sometimes there are cases where we have severe male factor, or sometimes we have no sperm coming out and ejaculate. We have to go into the testicle, biopsy the testicle, find the sperm, use that immature sperm, create embryos. And sometimes those cycles do not result in a favorable outcome or a failed outcome. Then we use donor sperm. We say, well, we should use donor sperm and bypass that problem. And all of a sudden you run into a situation where it's still a negative outcome. We transfer the embryo that was created from donor sperm, and supposedly assuming that the donor sperm is good, and it still fails, then what do you do then? Well, you kind of do something similar to that failed donor egg IVF cycle where you reset. You look at every single parameter, you go back, make sure you haven't missed anything or overlooked anything, or make sure that nothing has changed from that initial evaluation, which could have been maybe 2 or 3 years before the couple started their journey, right? So I typically go back and re-examine the uterus. I look at the egg quality. I look at all the hormone levels and try to identify whether there was an exposures, whether something changed in the medical history. Try to identify any other variable that could have impacted the outcome. Also, it's not a bad idea to look at the egg quality, because sometimes when you have sperm issues, you can also have egg quality problems, and it would be wrong to assume that the egg is perfect and you just use donor sperm and you cured everything. Well, maybe not really. And oftentimes there's more than one variable. Could have been the sperm and maybe the egg on top of that. So I think when you're using donor sperm and you're doing IVF or donor sperm inseminations, whatever the reason might be, or whatever the intervention is, you always have to go back, reset, and identify whether there are other variables that can or could be corrected. The other thing is, similar to donor eggs, oftentimes people assume that the donor sperm is perfect. And sometimes it isn't. So at the time of that particular collection, the sperm donor could have been exposed to something, or genetically there could be issues with that sperm. So it's not a bad idea to change a sperm donor if that type of an approach fails. And sometimes these sperm donors, they may have initiated pregnancies in the past, or they may have gotten other people pregnant. So they may have a good track record, but sometimes these sperm donors, they collect sperm multiple times. So the first couple of collections could have been great, and then the following collections, even though the numbers are good, on paper things look good, maybe the quality is not there. So that's still a variable. Unfortunately, there's just so many moving parts in what we do, and that's what makes it very confusing, right?
There certainly are. It's quite a bit. What about, and finally, I do want to talk about what if you have a surrogate and the pregnancy fails there?
Yeah, so the other question is, if a couple is using a surrogate for whatever the reason might be, for that, you have to do IVF, obviously. You cannot do an IUI with surrogate, right? So, what happens? You put an embryo and it's a negative outcome, which is certainly devastating. What do you do then? So when you're using a surrogate, it's a good idea to look at this from the analogy of kind of the seed and the soil that a lot of fertility doctors use as an analogy, which I think does help in this particular question. Soil being kind of the uterus of the surrogate, right? And then the seed being the embryo. So then you have to kind of break it down into pieces and take a look. And again, reset, just like we talked a few minutes ago about failed sperm donor or egg donor that result in a failed IVF cycle, kind of reset and break everything down to pieces and look at all the variables. Was there a problem with the sperm? Was there a problem with the egg? Were there any issues with their quality? Were there any issues with hormones? Was there something that went wrong during the IVF cycle? Was the quality not so good? Some people do PGT, pre-implantation genetic testing of their embryo. That's actually quite popular these days, especially in our practice. I think everybody wants to know what they're getting, even though it's definitely not mandatory by any means, and it's definitely not perfect technology. We definitely know that, but it's still quite popular. So when we look at embryos, were they tested or not? And if they were indeed tested, were these embryos normal? And indeed, if they were normal, what does that mean? Well, when you put back an embryo from the seed that we're talking about, right, as opposed to the soil, if that embryo is normal, well, it may just be normal for certain chromosomes, right? So this is a chromosome test where you're looking at whether there are 46 chromosomes or not. And that's fine. And if there are 46 chromosomes, that's a level of reassurance, although that still doesn't tell us about all the genes within those chromosomes, because there are thousands of genes in the human genome, and we just simply don't know which ones to look at, which ones are relevant, and which ones are irrelevant. So even though you might be doing the PGT, and you might be thinking, well, I have a perfect embryo. It passed the test. It can still be the embryo. On top of that, if you have a normal embryo based on this PGT test, but it's low quality, the embryo is low quality, it doesn't have a lot of cells, it doesn't really look great, it can still be due to the embryo, even though you're putting that embryo into a, quote unquote, perfect uterus in a surrogate, it can still be the embryo. And I've seen this over the years in my career where people have used a surrogate trying to get that perfect outcome and still failed because the issue was with the embryo and not really the uterus. Or it was the uterus and the embryo. So you fixed one problem, but the other one you were not able to manage. So that's an issue that can be associated with the embryo that results in the failed outcome using a surrogate. And then obviously there can also be issues with the surrogate, right? So that's the soil, where there's a problem with the soil, right? So the surrogates are typically young, healthy, screened for a lot of things, and they must have had at least one uncomplicated full-term pregnancy.
Okay.
Now that doesn't have to be a normal vaginal delivery. It can be a cesarean.
Oh, interesting.
But they must have had at least one uncomplicated pregnancy. So in a way, it makes them more of a proven kind of carrier in a way, because they did this once before, or they may have been surrogates before, right? Maybe they carried somebody else's baby. So they're, quote unquote, once again, proven surrogates. So in that case, we have to look at, again, their case a little more in detail. Is there an issue with the uterus? We may need to re-examine the uterus. We need to check the hormones of the surrogate, because sometimes hormonal issues can result in problems. We have to check their thyroid function and kind of overall reassess them. Did they take the medications correctly? Did they miss their medications? Because sometimes it can be as simple as just missing medications one day, and that can be an impact, especially in between the time that you start those medications to the time that you implant, and then you follow that patient later on to see if they're pregnant or not. And even during the pregnancy, sometimes, if you don't take these medications, you may end up with a miscarriage. So these are all variables that we look at in a case where a couple or a patient uses a surrogate and the outcome is negative. So all of these are variables. And if the problem's with the surrogate, there's some kind of an issue, you can fix the issue. I had a surrogate that I operated on last week. We screened her about a month or two ago, and she had a polyp in her uterus. Otherwise, a perfectly healthy young individual woman who had a baby in the past, and now she's trying to become a surrogate. But she just happened to have, I don't know where, a polyp in her uterus. So I operated on her, I removed the polyp. Now she's going to rest this month, and then rest another month just to have a natural cycle. And following those 2 months, she's going to come back, and we're going to place an embryo inside her uterus. So if we had not evaluated her uterus, that probably would have resulted in a failed cycle or some kind of a miscarriage. So now we're normalizing, restoring her anatomy, and her outcome should really be good and hopefully a positive one for the intended parent. So these are things that one can actually look at if the treatment fails, kind of go back, reset, and take a look and figure out whether there was something that can be fixed for the following treatment. And that would pretty much be what we would do if somebody is using a surrogate and that results in a failed outcome. Obviously, there are a number of other variables involved that kind of go beyond maybe the coverage of this podcast, but those are really the main variables that we would look at and make sure that we identify each variable and try to control them.
You know, this is so fascinating to me because there are many variables that come into play of success for a pregnancy or failed pregnancy. And just to overemphasize the fact that it's really important to go see a fertility specialist to really get all of the details, because, you know, we try to do as much as we can on our own at home. There are a lot of different tests you can buy now through the mail for fertility, but you know, you really need to go to see a specialist to really, look at all the different variables, not just from the female side, but from the male side as well. So thank you, Dr. Bayrak. I appreciate your time and spending with me today.
Thank you so much, Barbara. I think this was a really good, stimulating session.
Yeah.
I don't think we have done one that's quite broad, actually, I have to say. But I think we were able to cover quite a bit of ground here with a variety of different type of treatments. We started with surgical treatments and then kind of moved on to medical treatments and failed cycles and what we can do. So I think in combination with our previous podcast of failed IVF treatment, this does, I think, complement, add to it, and kind of completes what can or should be done, or what direction should one take with their treating physician if any or a type of fertility treatment fails. So thank you so much for hosting this wonderful podcast. I really enjoyed it. And you actually made me think a little more even now. Now I have additional ideas that I can do when somebody comes in for failed treatments. Thank you so much.
Okay, thank you, Dr. Bayrak. Until next time. Understanding Your Fertility is created by LAIVF. Please note that this podcast is intended for a broad understanding of the topics presented. It does not substitute for the medical advice or care of a physician-patient relationship. Podcast listeners should always consult with their healthcare provider regarding any medical condition that requires professional attention. Follow us on Facebook, Instagram, and Twitter. If the information on this podcast was useful for you, feel free to share it.